Over 50% of patients presenting to clinics with chronic neck pain are suffering from pain generated directly by the cervical facet joints. This pain typically originates from one of two mechanical causes. The first is insidious degenerative alterations to the joint architecture over time. The second is trauma, frequently resulting in whiplash-associated disorders, or WAD. WAD refers to a cluster of symptoms stemming from microstructural damage to the capsular ligaments following a rapid acceleration-deceleration injury, such as a rear-end motor vehicle collision. The neck is uniquely vulnerable to this type of chronic pain generation. Compared to the lumbar spine, cervical facet joints have a significantly higher density of nociceptive fibers, the sensory neurons that transmit pain signals to the brain. Patients typically present with axonal neck pain, meaning the pain is localized to the neck itself and rarely radiates past the shoulders. Crucially, they lack neurological deficits, such as muscle weakness or abnormal deep tendon reflexes, which would indicate a nerve root compression. This map illustrates predictable pain referral patterns linked to specific facet joint levels. The most frequently implicated are the C2, C3, and C5, C6 joints. Notice the distinct radiation zones. Upper cervical pain refers toward the occiput, while lower cervical pain spreads across the shoulder blade. However, these specific pain referral zones overlap considerably with other localized neck pathologies, like muscle tendinomyalgia. The patient's symptom profile and physical examination can point toward the facet joint, but they cannot provide a definitive diagnosis on their own. Faced with refractory neck pain, the standard clinical reflex is to immediately order an MRI or CT scan to visualize the tissue damage. This fails because diagnosing facet-mediated pain relies on locating the active pain signal, not structural wear and tear. Advanced imaging has very low diagnostic specificity here. Visible MRI abnormalities, like joint edema, correlate poorly with the actual generation of pain confirmed by functional diagnostic blockade. There are only two valid clinical reasons to employ advanced imaging in these specific cases, primarily for detailed procedural planning or to rule out severe red flag pathologies like fractures, tumors, or spinal infections. To isolate the facet joint as the true source of pain, clinicians use a functional test, the prognostic medial branch block, or MBB. An MBB is an injection of local anesthetic targeted directly at the small nerves that innervate the specific facet joint. Diagnosing cervical facet pain requires abandoning the search for a photographic snapshot of tissue damage. It is an engineering problem. You have to functionally disable the localized neurological pain signal to prove exactly where it is coming from. This flowchart outlines the official clinical practice algorithm for managing refractory neck pain. It begins with excluding neurological disorders, moves through the physical examination, and requires that a patient first fail conservative treatments, like graded exercise therapy, before any intervention is considered. If conservative management fails, the physician performs the diagnostic medial branch block. For the test to be considered positive, strict evidence guidelines require the patient to experience at least a 50% reduction in their pain. Historically, there has been a significant push in pain medicine to require two separate diagnostic blocks on different occasions. The rationale for this dual block requirement was to weed out placebo responders and lower the false positive rate. But the data shows that dual blocks are mathematically and clinically counterproductive in the cervical spine. Because the baseline prevalence of cervical facet pain is naturally high, requiring a second block drastically increases the false negative rate. It eliminates true responders alongside placebo responders, ultimately denying valid patients access to effective treatment. The medial branch block is also preferred over trying to inject steroids directly into the facet joint capsule. Intra-articular injections have a high technical failure rate, with over 90% of procedures resulting in extra-articular extravasation, where the fluid simply leaks outside the targeted joint space. Once a single medial branch block confirms that the targeted nerve is the pain generator, the clinical objective shifts entirely. The goal is no longer temporary chemical relief from an anesthetic, but long-term electrical denervation. That denervation is achieved through radiofrequency ablation, or RF treatment. This procedure precisely destroys the medial branches of the dorsal rami, the specific nerves carrying the pain signals away from the facet joint. This anatomical illustration shows the cervical vertebral column and the path of these nerves. Notice that each facet joint has dual innervation. To denervate a single joint, you must ablate the medial branches from both the segmental level above and the level below the affected joint. For example, treating the C4-C5 joint requires targeting the branches from both C4 and C5. There is a critical exception to this rule at the upper cervical levels, specifically at C3. At this level, the anatomy splits. There is a deep branch that innervates the C3-C4 joint and a superficial branch known as the third occipital nerve, or TON, which solely innervates the C2-C3 joint. The physical mechanism of RF ablation relies on thermal energy. A specialized needle is guided to the nerve, and an alternating high-frequency electrical current heats the active tip of the needle between 80 and 90 degrees Celsius. This creates a precise thermal lesion that interrupts nerve conduction. Because these medial branches are microscopic and exhibit high anatomical variability from person to person, the success of the thermal lesion relies entirely on the precise geometric alignment of the ablation needle. Physicians utilize three primary procedural approaches to align the needle: the posterolateral, the posterior, and the lateral approach. This cross-sectional diagram illustrates the three needle trajectories intersecting the medial branches. The core geometric principle of a successful ablation is maximizing the surface area contact between the active tip of the needle and the nerve itself. Look at the lateral approach on the right side of the diagram. This trajectory places the needle perpendicular to the medial branch. It creates a crosshair intersection, which provides minimal surface area contact between the needle tip and the nerve, resulting in a suboptimal lesion. On the left, you see the posterolateral and posterior approaches. These trajectories run parallel to the expected course of the nerve. By laying the active tip alongside the nerve, the physician maximizes the size and effectiveness of the thermal lesion. To execute this safely, many specialists use a tunnel vision modified posterolateral approach. By placing the fluoroscopic X-ray machine, the C-arm, in a lateral position, the physician gets a clear coaxial view of the needle trajectory, ensuring they do not advance too far anteriorly and transgress the spinal canal. These panels show exactly what this optimal placement looks like under live fluoroscopy. In the antero-posterior view in panel C, the final position of the needles rests perfectly within the concave waist of the facet column. Even with perfect anatomical placement, vital electrical safety checks are required before any heat is applied. The physician first applies a 50 Hz sensory electrical stimulation. This should produce a localized tingling sensation at less than 0.6 volts, confirming the needle tip is in close proximity to the targeted medial branch. Next comes the final failsafe, a 2 Hz mover stimulation. This test ensures there is no distal muscle contraction in the patient's arm or hand. If contraction occurs, it means the needle is too close to a ventral spinal nerve root, and applying heat would cause catastrophic motor damage. Radiofrequency ablation is not a blind injection. It is a rigorous, calculated exercise in spatial geometry and electrical conformation. Looking back at the bottom half of the clinical algorithm, we see the final pathway. If the diagnostic medial branch block yields at least 50% pain relief, the patient proceeds directly to radiofrequency treatment. This timeline compares the clinical longevity of these interventions. Intra-articular steroid injections typically provide a median pain relief of just 3 days. A medial branch block with local anesthetics might provide around 4 months of relief in a small subset of patients, but radiofrequency ablation extends that relief from 6 months up to 42 months. Randomized controlled trials, including foundational studies by Lord and Van Eerd, prove this efficacy. Their data shows that up to 85% of properly selected patients achieve at least a 50% reduction in pain for 6 to 12 months or longer following RF ablation. Based on this evidence, clinical guidelines explicitly advise against the routine use of intra-articular steroid injections or botulinum toxin for cervical facet pain. There is no place for surgical fusion in treating primary non-radicular neck pain of this type. Successful intervention for chronic cervical facet pain demands clinical precision. It requires discarding non-specific structural imaging, relying on functional nerve blockades to prove the source of the pain, and executing strict fluoroscopic geometries to permanently ablate the offending signal.